Let us see retinitis pigmentosa. So this is a fundus photo of a patient with RP. As we know, RP has a classic triad. And if that is seen on the fundus photo, it is very easy to diagnose the patient as having retinitis pigmentosa. First and pathognomic is the arteriolar attentuation. That is the narrowing of the arteries and they become thin and sclerosed. We see a waxy disc pallor in late stages. And the striking feature is the mid-periphery bony spicule pigment deposition. So these three form the classical triad of RP. We can also notice that the fundus here has a very tessellated appearance and we can see the underlying choroid. So why do we see this triad? What is the pathophysiology behind this? So let us move on to the layers of the retina, which will be easy to understand why RP involves these changes. So the pathology in RP is in the rod outer segment. It can be a rhodopsin mutation RP, or it can be the other modes of inheritance of RP, wherein the outer segment of the rod is affected. As we know, rhodopsin is contained in these discs in the rod outer segment. Because this is not normal, the RPE with the macrophages, RPE and the macrophages will phagocytose the rod outer segment. So this leads to loss of the rods, which are eventually all destroyed. Okay. RP typically, as we know it, is a rod and a cone dystrophy. So why are cones affected? So there are many theories to explain this, but it is said that the cones depend on the rods for their viability, and also a secondary pathology develops in the RPE as a result of the phagocytosis, because of which the RPE is unable to support the cones. Okay, so the rod dystrophy progresses to involve the cones as well. So once the disease progresses, we see that the outer retina is destroyed. And as this is destroyed, its vascular demand decreases. Decrease in the vascular demand of the outer retina is why these blood vessels attenuate. So this is why we see the arteriolar attenuation, okay, because of the outer retina which is destroyed. Also what happens is, because of this attenuation, there is a hypoxia that leads to a damage of the inner blood retinal barrier, which these arterioles are a part of. So what happens is the inner blood retinal barrier is damaged. So the RPE cells now will release pigment, okay, and this pigment migrates along the blood vessels to the inner retina in an attempt to restore this damaged inner blood retinal barrier. So this pigment migrates along the blood vessels, more typically along the venules, and it tries to restore the inner blood retinal barrier by bridging the tight junctions. This is why we see perivenular pigment deposition. The way this pigment deposits is how a new bone matrix is formed. The appearance is thus like bony spicules. Okay, so we have seen arteriolar attenuation, we've seen bony spicules. Now let us see what happens further. So once the rods and the cones are affected and the RPE is affected, the disease progresses. Okay, and it eventually involves the ganglion cell layer. So once the ganglia are affected, that is in the later stages of the disease, we see a reactive gliosis. And this leads to the waxy disc pallor. This is the third part of the triad. So this explains why we see the fundus changes in the patient of RP. So once this RPE has released its pigment, now the RPE cell lacks pigment, right? So it is easier to see the underlying choroidal blood vessels, and thus it gives the fundus a tessellated appearance. So this is why we see these changes in the patient of retinitis pigmentosa, and we can see the characteristic triad. Thank you for